Welcome back. Let's continue. Now that we've taken a brief look at schizophrenia, let's turn back to the eye. And in this presentation, we will explore the anatomy of the retinal layer, which is the innermost layer of the eye. The outermost is the conjunctiva and the sclera, and the middle layer is the uvea, anterior part being the iris and the ciliary muscles, and the posterior part being the choroid layer. And within the retina, if we face it straight on, there are different parts. You can see the vessels of the retina, and both the veins and the arteries can be seen if you use fundoscopy to examine the patient. And there are also something called the fovea and the macula. And the fovea is where the light focuses on when you're looking at something. This takes in information for your central vision, and this is lined with around 4,000 cones and no rods. And surrounding the fovea is the macula. Macula has the highest concentration of the cones, and this entire structure lies more temporally into the optic disc. Speaking of the optic disc, this is where the ganglion cell axons gather together and exit the eye as an optic nerve. And this connects to the brain as a second cranial nerve. Because this is a spot for the gathering of the nerve axons, the light hitting this area cannot be turned into a sensory information because there are no photoreceptors. This is referred to as our blind spot. And if you hold out your finger right in front of your eyes and gradually move it further and further away, there will be a point where you won't see that finger anymore, and that's because the light from your finger has hit your blind spot in the retina. And even within this one retinal layer, there are multiple layers. The light first comes in through and passes all the neural layers until they hit the photoreceptors, ironically, and then the signals from the light gets passed back to the plexiform layers, the bipolar and the horizontal cells, the ganglion cells, and that eventually goes into the optic nerve. And look at how many layers there are. We won't go into detail in this presentation, but just know that it takes this many layers to interpret and take in visual information. And this is a more visual illustration of the layers that were stated in the last slide. And so you see the bipolar layer, the horizontal cells, photoreceptors, the retinal pigment epithelium, as well as the Brooks membrane that divide that acts as a border between the choroid and the retina. And with the eye overall, the light first passes through the cornea and the anterior chamber. The iris can constrict or dilate to control the amount of light entering the eye. The light then passes through a clear lens, which then goes through the vitreous before hitting a specific part of the retina. So now that we've learned some of the anatomy of the eye, let's dive back into how schizophrenia is related to some of the eye abnormalities. So we should note at this point that schizophrenia is a hyperdopaminergic state. In contrast, Parkinson's disease is a disease that lacks dopamine. So they are opposites, which means sometimes when you're treating schizophrenia by depleting some of the dopamine production, this can cause some Parkinsonian symptoms and vice versa. And when there is a high level of dopamine, there are four dopamine-specific pathways in the brain. In schizophrenia, the mesolimbic pathway is elevated, saturated with dopamine, and causes positive symptoms. In contrast, the mesocortical pathway observes a dopamine hypoactivity, and this causes negative and cognitive and affective symptoms. Some of the drugs can cause the other systems to go activate too much, and some of the typical antipsychotics actually can overactivate the nigrostriatal and the tuberal hypophyseal pathways. So although in the mesocortical pathway dopamine is hypoactive, overall in the system there's an elevated level of dopamine, and high dopamine in the brain means high dopamine in the retina, because they're very close and linked with the optic nerve. High dopamine in the retinal D2 receptors, especially in the cones, this causes hyperintense perception of color. This in turn means that the patient will experience difficulty sensing contrast. So contrast, if you look at the picture right below that bullet point, you'll see a white background with black letters, right? And contrast is simply our ability to distinguish that difference in the shading. Some of the schizophrenic patients and others with impaired contrast sensitivity might have more difficulty than others to read some of the letters in the lower lines. We have already discussed that in schizophrenia, the macular volume and the macular area diminishes. And because the macula and the fovea are responsible for central vision, this atrophying causes diminished visual acuity. And in just the previous slide, we discussed that schizophrenia with that excess level of dopamine can cause decreased contrast sensitivity. Now it's time to talk about the movements of the eyes. And take a look at this picture here. The series of pinkish purplish dots are indicating what the participants see at any given time. So in healthy participants, when they were given a new picture or a scenery, their eyes move all over the picture. They try to see everything. It's exploratory. But in comparison, participants with schizophrenia, their eyes tend to gaze at a very localized fashion. Their exploratory eye movements, in other words, is very limited. And not only that, while looking at this scenery, when there was a visual pursuit, when there was a moving object, there was a little difficulty in maintaining that visual pursuit. The eye could not track the object that was moving, and because it kept slowing down, but the brain orders the eye to keep up to that target, the eye adjusts with the rapid late saccade to catch up to the moving object in focus. So these are some of the eye movement abnormalities that could be very interesting for future research. Now, one sign that you can observe in the eye with the schizophrenic patient, demonstrated by several studies, is widened retinal venules. So when you're looking at the back of the eye with a fundoscope, you will see that there are these vessels spread across the retina, like in this picture. But they are not blue and red. They're all very reddish. And the one way to distinguish between venules and arterioles is by the width. venules are generally wider than the arterioles. But what I mean by widened retinal venules is that the discrepancy of the width between the venule and the arterioles are exaggerated in those with schizophrenia. So they will look abnormally larger and wider. So what I've described so far, the symptoms and signs of retinopathy and eye movement abnormalities, sound very qualitative, shall we say. You're probably wondering if there are ways to quantify these findings, and there are some investigations that can be done in terms of retinopathy. We'll introduce the OCT and the ERG. First, the OCT is optical coherence tomography, and this is a non-invasive imaging modality that uses light waves to take cross sections of the retina. This is great for measuring the thickness of the retinal layers, and actually, if you remember how I mentioned the RNFL is thinned in those with schizophrenia, well, you can observe that here. In ERG is electroretinography. This is a method where an electrode is attached at the cornea. This electrode detects the electric signals from the photoreceptors at the retina. Any abnormal signs would indicate problems in the retinal layer. And also in schizophrenia, the ERG tends to demonstrate a diminished rod B wave amplitude and longer latency. Now that we have discussed the signs and symptoms of schizophrenia and the eye abnormalities, and also explored the eye anatomy, in the next video we will discuss the treatments, the prognosis, as well as the future potentials of the connections between schizophrenia and the eye.